almost a decade ago, this board took the courageous step to make a transition in thinking, and that the children of South Texas that we've always taken care of doesn't start at birth, but it starts at conception. And with that, we added our first miracle in a series of miracles in this story. We decided as a board that we would bring in high-risk obstetricians all throughout South Texas to take care of the fetus inside that mother's womb. And today, I'm proud to say, because we knew in Conjoined twins that 54% may not make it just in the delivery process. Today, I'm proud to introduce the director of our maternal fetal program, Dr. Ryan Lofton, the first part of the miracle of these small children. The second part of the miracle that's just incredible because it was an 11-month miracle is those children after delivery were extremely frail. It was just the miracle that I saw for 11 months through Dr. Miguel De Leon, the medical director of the neonate ICU, your children staying in the ICU being cared for 24/7 every day, even thinking about behavioral care. How are these children going to see the world when they grow up? Those are the type of things that allowed Miguel De Leon to allow those children to thrive. Now, I think we're all here today because we're celebrating an event that happened this week, which is the next teamwork miracle. Now, if you're an adult and you have surgery, you talk about your surgeon. In children's world, in this children's hospital, you don't have your surgeon. Many surgeries are 3-4 surgeons working in a coordinated fashion to provide the best care at the end of that surgical. Almost no one in the world has done this with 20 surgeons. The Man on the Moon event, and I almost have to say it the right way because I don't want to get it wrong. It's where the teamwork approach is miraculous, where a common mind that's been knitted together by the hard work of these surgeons for month after month is executed flawlessly by each one of them. And then as that one left the table, it was seamless, and that the next one would just continue the same surgery. The anesthesiologist that stayed there, the entire team, and came together as a team, all of this is a miracle. And we saw it down to the last suture with a common mind and a common purpose. And so I would like to introduce our surgeons that did this work. Dr. Steve Alman, Department Chair of Surgery, Pediatric Surgeon. Dr. Bill Grimes, Director of Anesthesia, Pediatric Anesthesia. Dr. Banderi, and I'm sorry, Dr. Banderi, I know you so well, it's Angelina Banderi. Yes. So, pediatric anesthesiologist, Dr. Mohammed Imran, pediatric surgeon. There's a guy in the middle I'll wait for. Dr. Kevin Hopkins in plastic and reconstructive surgery just for pediatrics. Dr. Omar Cruz Diaz, pediatric urologist. Dr. Roger Timberlake, pediatric orthopedic surgeon. Dr. Chris Comstock, pediatric orthopedic surgeon. And this guy in the middle, who is a team leader with Miguel De Leon, in this entire series of 4 miracles, Dr. Haroon Patel. And Haroon, Miguel, a round of applause. Let me say the miracle doesn't stop there. The miracle starts at birth. It starts at conception. It goes through 11 months. It goes through this surgery. And now Dr. Carl Maher, minute by minute, and sometimes second by second, is creating another miracle, because those kids are getting the best care every second in your pediatric ICU. If you want to look at the most complex ICU care in the world, go up to Carl's unit. Carl, thank you. So with this, I'm extremely proud as a small player in Driscoll Children's Hospital to extend these words to this team that did so much, and express my thank you for the entire Driscoll system, for the mother and the father, for the children of South Texas.
Thank you, Mr. Warner. Now I'd like to introduce Dr. Arun Patel.
If I can work this, I'm not very good with my hands. Uh-oh, broke it already. So, I'll leave it like that. Thank you very much. This is been a phenomenal week. It's a great, I want to say it's a culmination of multiple months of preparation. And thank you, Mr. Warner, for those kind words. I'm getting a little feedback. Are you guys getting feedback? Maybe I'm too close. The unsung heroes need to be acknowledged in this here. The doctors that are sitting here cannot do this by themselves. As much as the work was complex, as much as the care of these fantastic, wonderful infants and their families is complex, it needs to be said that, as Mr. Warner pointed out, the teamwork was just phenomenal. And this has been going on for the last several months. We're thankful for so much. We're just blessed that the parents chose Driscoll Children's Hospital as the facility to take care of these obviously rare and very complex set of twins. And having said that, we undertook the task of making sure that we try to do right by them and just do right by the kids. And from day one, we've been planning, meeting, lots of meetings. In fact, people are getting tired of meetings, but we're meeting basically bi-weekly, preparing for this. And it's not just the people sitting at this podium or this front desk. There are countless nurses, technicians, therapists at Driscoll Children's Hospital that need to be acknowledged, because we just could not do this without them. And I'm just delighted and so pleased with the way things worked out this week. And I think it speaks to the preparation that went into this. You can never be too prepared for something like this. And I think the amount of preparation was enough to make people comfortable that we're as prepared as we were going to be, and we were as ready as we were going to be. And I can say, without being biased, without a doubt, that things went as smoothly and as well as they did because of the preparation and the great support that all of us received from the multiple people that work at this great facility. So I think we should give them all a round of applause, which I think is So I was going to make a few comments about the actual procedure, because I know that's why you're here. We've given you information before. We have some aids at the back here in form of a slide presentation. Some of this you have seen before. This is to aid some of my colleagues as a refresher if they want to talk around it and answer questions about it. But obviously we're here to discuss this week. And as I mentioned, things couldn't have gone better. On Tuesday, we started real early. Thank you, anesthesia. Appreciate it. a lot of things happened the day before. We had our anesthesia colleagues and our IV nurses place special lines so that these kids could be monitored during the operation and even afterwards. And this took place the day before. They had several things done to them to optimize them for the procedure. And this is routine for complicated cases where they have bowel surgery and multiple organs involved. But so Tuesday morning, we're able to take the surgery, and I must say that I know that we released guesstimates of time. And if you look at how long people have taken to do an operation like this, we were using this as a ballpark figure. And initially we said it was somewhere going to be between 12 to 18 hours, or even longer if needed. Again, with the help of Drs. Imran and Dr. Allman, I'm especially partial to them because they're my partners. I think it was just phenomenal having seasoned surgeons work with you, assist you, look in on you, provide mentorship, provide another perspective, another thought. But we had an idea of what we wanted to do, and once all the anesthesia was done and we got started, within 3 hours we had the twins separated, which was, again, not necessarily an indication of the skill of the surgeons, but just, again, the preparation, the knowledge about the anatomy, going over the radiologic studies, and just being prepared for what we were dealing with. So I was very pleased with that, and surprised, but extremely happy with that. The twins were able to be separated after about 3 hours, and then we were able to move one of the twins, Jimena, to another room where we had everything prepared, a second set of surgeons to take care of things. Of course, there were multiple procedures along the way, and so not everyone was operating all the time. But if I had to use a cliche, it was almost like an orchestra. Everything just came together perfect. I hate to say music to my ears, but all the preparation was just perfect. It was just seamless, where the pediatric surgeons were done, the orthopedic surgeons were able to come in and do their part, and I'll let them talk about that. The urologists were able to do their part, the plastic surgeons were able to do their part, and it was a lot of back and forth so that there was no downtime or no lost time. It wasn't exactly us sitting in the lounge and shooting the breeze or looking at our phone. A lot of it was just back and forth, making sure everyone knew their place. And I'm glad to say that everyone, from the nurses to the techs, everyone was in position and they performed their tasks seamlessly, so we're very pleased with that. I'm going to go through some of these slides just to show you some of this, and then we'll pass it down the line so that we can get a comment from everyone at this table, and where feasible, it might not be any strict order, but where feasible, we'll have the specific specialists talk about that particular aspect. I think you've seen some of these slides already, and I'm going to look back because I don't have a screen, and it's not like the nice TV in the front here. Mr. Warner, where is it? But these were the twins when they were born and transported to Driscoll Children's Hospital. And as pointed out, Dr. Lofton from the Maternal Fetal Medicine Service is here. He's going to talk some about their care before, just to give you an idea of the complexity. I know Ryan sent me an image, the wonders of modern technology. I think I was sitting in South Africa and he sent me an image of a conjoined set of twins on ultrasound, and it said, "Hey, you up for this?" Ryan, you want to talk about that?
Sure. So, as Mr. Warner alluded, the care of these twins really started well before delivery. And we shouldn't forget this was actually a triplet pregnancy with even more complexities. I had a meeting with the doctors from Brownsville that we worked with last night, and certainly our general obstetrician colleagues throughout South Texas work very hard to identify patients at risk and get them to our service for increased surveillance with ultrasound and diagnosis. And I first met the mother of these babies at about 23 weeks. And my initial impression, looking at the referral report, was triplets with conjoined twins is extremely rare and highly unlikely. And then very quickly realized this was really what we had. Not only that, this was a set of identical triplets, one placenta, 2 amniotic sacs with conjoined pair, 1 umbilical cord going to conjoined pair, and 1 going to the other identical triplet. So this amounts to about the most complex pregnancy that I can imagine. We had long discussions that day with the family and talked about the risks of conjoined twins, the risks of having a shared placenta, and risks for twin-to-twin transfusion syndrome and other concerns. We had the discussions about maternal risks because this type of pregnancy puts an undue amount of stress on the maternal body, and understanding the changes that go with pregnancy that requires this amount of support cannot be taken lightly. And yes, I did reach out to our colleagues here. I am very lucky to work with a wonderful group of specialists here at Driscoll Children's Hospital. We have a very well-staffed and very well-run children's facility. And I had a few doubts that we would be up to the task, but again, the first step started really about 15 months ago with our first discussions about, is this something that we can do? And we probably had 25 meetings before delivery related to how mom was doing, how the babies were doing, and how do we get transport arranged, how do we arrange the OR. We had to coordinate staffs at our delivery facility with 24-hour on-call transport services, so our transport services director and his team, the labor and delivery nurses, the neonatal intensive care nursery nurses from Bay Area Medical Center, and our teams here had to be in constant communication. And we were very lucky to be able to get her as far along, almost 34 weeks, which is in itself a feat, requiring a lot of inpatient ultrasound work and frequently multiple time a day management of mom with her pregnancy. Her delivery was complicated, as we would expect with such a large uterus with 3 babies and a lot of amniotic fluid. But working with our anesthesia colleagues on the maternal side, we were able to prepare for that and had a very good outcome for mom. And with the transport having done dry runs and been prepared for what was to come, really the transition from fetal life to newborn life was as seamless as I could have hoped it could go. And from there, as a maternal fetal medicine specialist, I transfer the care of these babies over to my colleagues here. And they have done an incredible job of managing these babies for the last 11 months. And certainly culminating in the long surgery that was performed today, or earlier this week, but countless hours spent coordinating care. And I want to applaud all of the services in all of the hospitals involved in the care of this pregnancy and these babies. And the coordination of care really is what makes this team work. We do this for other patients. We do this on a regular basis. And this is just a shining example of the amount of support that can be coordinated and pulled together for complex cases. And again, I'm very proud to be a part of this team.
Thank you, Ryan. Dr. DeLeon, you took over from Dr. Lofton. I got you want to mention a few brief words about the care up to this point? I know it's 11 months, so I'm going to cut you down to 1 minute.
Very proud to be here and very honored to be part of the team. We knew about this pregnancy, as Dr. Lofkin was mentioning, a few weeks before they were delivered. Obviously, it is a challenge, but thanks to a lot of the technology and the help that we have prenatally, we managed to get this pregnancy far enough that make our job relatively easy, in a way. We had several meetings with my partners, which I'm very proud of them, that we can coordinate the care efficiently, as complex as it may be. We were there at the time of delivery, and obviously, at the time that this was happening, we had already rehearsed what was going to happen, who was going to do what, just like in any other complex deliveries that we have. So everything was very well prepared. We had some practice as far as how they were going to be transferred. Again, as you can imagine, the complexity of this baby being conjoined, it really poses a big challenge, especially from the medical management standpoint. It's very unusual, and we have to adapt all the way from incubator, transport team, pressures, ambulance, so all that had to be prepared, and let alone the fact that we didn't know when the delivery was going to happen during the weeks prior to the actual event. So we had to be prepared at a moment notice for what was going to happen. Obviously, we were there at the time of delivery, and as early as they might have been at 24 weeks, it was farther than what we originally anticipated that they were going to be born, which again made our job a little bit easier. But thanks to all the coordination, all the support that we have from the multidisciplinary care that we have, including nurse practitioners, again, my group of neonatologists, the nurses, the respiratory therapists, so I can, transport team. We have a large number of people that participated and made things run real smooth. So we moved them over here, obviously the conjoined and the non-conjoined twin. Triplet, and she did very well. Actually, she went home and with not much of a problem. The Jimena and Scarlett stayed with us, as we were mentioning, for the past 11 months. We have had a lot of medical challenges during all this time, and again, thanks to the teamwork that we have had, things have run relatively easy and smooth for this big day, for this week. So we managed to get a lot of the information, and with all the coordination, the care of all the multi-specialties, we also made the decision of this separation to happen this week, in an attempt to get the most optimum outcome for them. And they did very well. We got very attached to them. We miss them in the neonatal ICU. They had been transferred to the pediatric ICU after the surgery, but we bond with them and with the family. We have a lot of ancillary help in the neonatal ICU, physical therapists, speech therapists, nurses, nurse practitioners, respiratory therapists. So I can't go down the long list of help that we have had in the neonatal ICU, but all that care have made it happen to get to the point where we are. They have grown very well, very healthy, and again, we optimize the care so that they could be in the best shape possible for the big day. So thank you.
Thank you, Miguel. It's about separation. I know you guys are dying to hear about the separation. So because some people still have to work today, and so I'm gonna maybe jump back and forth, but I'm gonna ask Dr. Allman, who is a pediatric surgeon, also chief of our transplant division. Dr. Allman, Amber, and myself did the separation, and then once it was separated, we split up into two groups, and Dr. Allman and I stayed with one patient, and Dr. Imran and our urology colleagues went into the other room. Steve, you want to talk about any of those aspects, your thoughts, how things worked out?
Thanks, Haroon. I would just echo some of the previous thoughts. Happy and fortunate to be here. Procedure went very well, mainly because of preparation. I used to have an old football coach who said, luck is when preparation meets opportunity. We were very well prepared for this and went very smoothly. A lot of reading, a lot of preparation. Not really much to say about the procedure. I'll let Arun go through that. I'm sure he has some beautiful pictures to share with you. Just like I say, I'm glad to be here. I thank God that the procedure went well and that He is going to heal these kids. We fix them, God heals them. Thanks.
Thank you, Steve. Dr. Mohammed Imran's the other senator was on there, Mohammed.
Thanks, Ren. This was, again, echoing everybody else, this is a great team effort. This was actually a rather fun operation because we don't often get the chance to work together as closely as we all got to work in this case. And because of the preparation, there was really a lot less stress than with a lot of other cases where we don't know what's coming through the door and we just got to take care of whatever it is that we find at the time. So this was really a really pleasant experience to be able to share that with all these people up here. As far as the surgery itself, no big surprises because again we had our radiology colleagues had really helped us define what was going on the inside. Dr. Patel had looked on the inside a couple of times with laparoscopy and been able to kind of determine what we were going to be running into, and so we had it planned down to what was going to go with which patient early on. So that took away a lot of the stress. I mentioned before we got to the surgery about some of the new technologies that we had, and a lot of those played a huge role. I want to thank the reps for those companies who were here on site helping us during the whole time to make sure that those pieces of technology worked properly and gave us the information we needed to really complete this as successfully as we planned.
Thank you. I'm glad you guys are clapping for them because the only thing I was doing was beating up on them this last 11 months. But that's my prerogative as the team leader. It's about the only time I get to be a boss because I can't do that at home. So, we had a bunch of new technology, and I'll be showing you some pictures. Some of this has been used in the adult world, never in the pediatric world, and certainly never on conjoined twins. And a lot of this was brought to our attention by Kevin Hopkins, sitting on my left, our plastic surgeon, and I thank him for bringing some of these people here. We were also able to, and I'll show you some pictures, but we were also able to live stream this for, I know the media's going like, what? We weren't invited. But this was for Driscoll people, and I think the feedback that we got was phenomenal. It was an opportunity with parental consent, of course, for us to live stream the operation so that the entire Driscoll system had the opportunity to share in this momentous occasion. They had two requirements. They had to check in the cell phone and make sure they didn't throw up or faint when they saw blood. But basically, they had a great chance. People enjoyed it. People were able to see what we're doing, interact with the surgeons in real time, and we had it moderated by our excellent moderator, Dr. Grimes. And I'm going to move over to Dr. Grimes and Dr. Bhandari because guess what? As much as surgeons think they can do everything, they can't do it without anesthesia. So I'm going to let the anesthesiologist comment about how the twins did during the surgery.
Every time I see Dr. Lofton, I thank him yet again for working with Mom, keeping those babies on board for 34 weeks. So by the time we got them on the first day of life, Dr. Patel brought them to the operating room so we could look in their bladder and rectum. They were in pretty good shape for being 6 weeks premature. Dr. Lofton giving them the drug that helps the lungs mature. Dr. DeLeon engaged their primary resuscitation. They were able to tolerate first day of life, full-blown anesthetic, and have tolerated them very well for all the other diagnostic and therapeutic procedures that have been done. The separation was an order of magnitude. Bigger surgery required a very special anesthetic. Also, teams of anesthesiologists that would take over every 6 hours. We had that were staggered. We had at least 2 anesthesiologists with each child at all times. The department that often seems like herding cats were able to very rapidly come together, agree on both the schedule and the anesthesia plan. Dr. Bandari was much more the driver with the anesthesia plan itself, so I'll turn it over to her.
Thank you, Dr. Grimes. The challenge of the conjoined twins for anesthesia is that everything was double, and how the medications and the pharmacology would react with the children. So it's all new. We did a lot of research and looked up and actually reached out to other colleagues in other institutions who also probably just done one themselves. And based on that, we came up with a plan and formulated a plan with on my anesthesia colleagues. And we looked into see how we could decrease the amount of blood loss and how we could make sure that they were stable at the most critical part. And we practiced and we went over scenarios, possible scenarios of complications, and we practiced that in the OR. So we were talking about being prepared, and it was everybody else in the operating room, the nurses, the techs, also prepared, and everybody brushed up on all the resuscitatives if it was needed. But I was glad to say that it actually went really well, and they're doing, they did really well during the procedure, which we were very happy about. And it's thanks to everybody's efforts and teamwork.
Thank you, anesthesia. That's the last time you're going to hear me say that. That's all good. I love it. I'm going to hand over to our orthopedic surgeons here because I got some pictures and I know some of them may have to run back and operate, but behind me is some of the models. We were able to work with a company that was able to generate 3D models. And you see some of them out there on the table on the side, allowing people to work with this, see what we were dealing with, play with the models, get a sense of what we were dealing with in terms of the anatomy. They were also able to generate virtual images that we could play with. Looking at the internal organs, we had plenty of radiologic studies, MRIs, CAT scans, you name it. And we got a lot of information. Radiologists were right in there explaining things, looking at things. But even the best studies sometimes didn't show everything we needed to. And the use of the virtual technology was pretty amazing. For example, one of the twins, Scarlett, had what we call pelvic kidney, much lower than we appreciated. Based on the studies that we had, we were able to go back and say, oh yeah, that is a lot lower than we were anticipating. So again, these are just some of the models that you see, and they were able to do it with just the skeleton and the organs, and then also with the soft tissue. Now I'm going to hand over to our orthopedic guys because I heard all kinds of things about what they broke the bones. Can you tell us some more, Chris and Roger?
Thanks, Rude. That picture on the left, I think, is a good one to look at. The twins essentially had spent their entire time with their legs widely apart, and their pelvis, the fusion occurred at the pelvis. So we have one very, very large pelvic ring, and each twin has to have their own pelvic ring. So a lot of these computer animations were very helpful in helping us determine how to bring this together. And Bruno, if you have, I don't know if you have a pointer.
Yeah, I don't think the red pointer shows up much. It's here. Right. If not, you might have to talk to it. Yep.
If you can see that now. So if you first look at the picture, it's not actually intuitive on which legs go to which twin. So if you take a moment and just look at that picture, you wouldn't know if the two legs to the left go to one twin, the two legs to the right go to one. But it's the ones up above, the two on the top. The two bones, the two legs up on the top screen go to the twin on top, and the two legs on the bottom go to the twin on the bottom. And they're fused. I can get this to work.
Yeah, I can't really see.
No, that's right. Yeah. They're fused right in the. Dr. Jim likes
I love Roger.
So they're fused right where Dr. Chimlick was just pointing. One right there, and then one right there. And so that's where Dr. Patel separated and was right at that spot. And then the hard part began was that they didn't want to come together. So that was our part, was to bring the pelvises together. So we had to make, and it's what Dr. Tell is referring to, the cuts in the bone. We had to free up the bone in order to bring the pelvis together. So we had to make actually 4 separate cuts, one in each pelvis bone as shown on. Yeah. So right in the back part of the pelvis is where we had to make the cuts. And the challenging part of that is right behind all that are the major blood vessels and nerves that go to your legs. So we were at great risk of causing great damage if we got into trouble. And fortunately, it all went very smoothly because the blood loss can be very extensive. Those are the major arteries, major nerves that are going there. And so we had to be very careful. And so we made complete cuts all the way through and actually had to remove some of the bones so that we could actually bring the pelvis together. And then in the front, that's in the back, so we did that on the back of each one. So all 4 of those bones we had to cut through. And then in the front part, we had to bring that together. They were widely displaced, and so we had to close the pelvis into a more normal pelvis. So we had to wrap, they were almost looked like a shoelace. We had to wrap these wide bands of material around the front of the pelvis and then bring that together. So the cuts in the back helped free up the bone, and then we were able to bring it together in the front to close the pelvis. So the nice thing with that is that actually brings their legs down into a more normal position. Their legs have been, essentially they've been doing the splits for their entire life, and now we're trying to slowly bring them down into a more normal position. That was our.
Thank you very much. All the guys here, but Roger Timberlake, I mean, it's something else. You know, I got to tell you a little story, a side story. So, 2 things that Roger was just, what can I say? It was impressive because as I was trying to figure out and talk to the different surgeons who wanted to be with which twin, and we gave them choices, who preferred to operate on which particular twin based on the anatomy and so on once they were separated. Roger's reply was pretty simple: "Coach, put me in." So that's the one thing. And then I don't know if I can mention Roger's prayer. We did pray beforehand, but I did particularly produce Roger's prayer. And if it's with your permission, I'm going to say, go ahead. He had a very nice prayer that he shared with us. He said, "Lord, don't let me screw up." I'm going to ask our pediatric urologist, Dr. Omar Cruz-Diaz, to talk about the urologic aspects. Dr. Leon Smith-Harrison is one of our other urologists. He could not be here today because someone had to work. Others mentioned that, you know, they were certainly challenging. I took care of one of the twins, and they did require the ureters, once they were separated, and I'll let Omar tell you some more, but once they were separated, we were able to connect the ureters in Scarlet, and they didn't have to do as much work on the urologic aspect as it did in Humana. But Omar, you want to tell us some more about the urologic aspects of the surgery?
Sure. Good morning, everybody. I don't want to sound repetitive, but of course I'm thrilled and excited joining this great, excellent group of physicians. And Dr. Smith-Harrison, Dr. Patel, and myself, we work on the plumbing or the urological aspect of the twins, and also on her reproductive or the genitourinary tract areas as well. Each twin present unique challenges. Scarlett had a pelvic kidney, which that means that the left kidney was located quite low in the, towards her pelvis. So do I have a, you know,
The pointer doesn't really work.
I know, but I saw some mics Can I just grab a mic and,
Yeah.
and talk there?
Yeah, sure, go ahead. I also use the pointer on
Use the
the
pointer there.
mouse.
There's a
Use
pointer on the mouse.
on the mouse there.
Yes,
Right.
all right.
Yeah.
That will work. So, as you can see here, this is great model representation of Jimena, and this is Scarlett. And when they say that they share bladders, that was true. There are two separate urinary bladders. So this left kidney on Jimena drains here, the right kidney on Scarlett drains here. So the same thing happens on the other side. Right kidney here, left pelvic kidney draining here. So there was, besides the bladder, there was the adelphous uterus or duplicated uterus underneath here, and two hemivaginas as well. So as part of the strategy for their division, we needed to keep all this as a unit as much as possible. So Dr. Haroon, Dr. Allman, and Dr. Emran, when they did the initial division here, they preserved, well, we were talking about keeping the right with the right. But definitely the vascular supply was confirmed as well during surgery. And it was very convenient to keep this structure and block for Jimena, for Scarlett, and this one for Jimena. So basically, when Dr. Kamster and Dr. Timberlake developed the pelvis, this entire unit moved in this direction. And this unit moved towards the center here. In order to do that, the left kidney was separated from this bladder, and this left kidney was separated from this bladder. In the different operative rooms, Dr. Patel connect the ureter of this kidney to the ureter of this right kidney that was already draining on the right, on this bladder. In previous imaging studies, this kidney on Jimena had no renal function. So we thought that it was appropriate to remove that kidney. We kept the ureter and we replanted here, and this kidney was associated with vesico-ureteral reflux. So we also do a ureteral reimplantation to try to correct the urine reflux into the kidney. And as soon as these bones or the synthesis were brought together, the genital bladder, everything was lined almost perfectly in the real one. I don't want to say perfect, but it was very close, because this was a concern at some point that the genitalia may not be oriented mid-center, that it may be lateral in this place. But as echoing Dr. Patel's word, I think that this runs so seamless, and the orientation of the genitalia, they just reach the area where they are supposed to be, and at the end, it has been a great success, a great outcome for this patient. Thank you.
Thank you. Moving right along, once again, the back and forth, different parts being done by different surgeons. Plastic surgeons were there from the beginning. I don't want you to think we just left them for the end. They were there initially. Dr. Hopkins, we actually brought some equipment in. There's some slides I'm just going to go through here because they're showing like the operating room set up at different times, the various personnel. I'm going to let Dr. Hopkins talk about this briefly because they came, they had some stuff done before, but they were also able to do things for us before we started and then do the final closures. So I'll bring it up here if you want.
Yeah, they're trying to use it.
Okay, right there? Yeah.
Thank you. Can you hear me?
Yep.
Okay, thank you, Varun. Again, I want to echo what everyone else has said. This really is a team approach, and Dr. Patel did a tremendous job in bringing all of us together as a team to do the best as possible for these twins. We always, seriously, we always expect the worst and hope for the best, and to be over-prepared is the way to go. This type of union that these twins had was right here at the pelvis, as you know, and probably of the types of conjoined twins, this is probably the best, most favorable one for having soft tissue coverage. So as plastic surgeons, we're always worried about once you separate the twins, how do we cover the gaps that are left behind? And so again, we try to be over-prepared preoperatively by having, I think in our first press conference, so we took these balloons that we fill with water underneath the skin here, and we fill them up every week until you get to a maximum expansion. Again, I want to thank my colleague, Dr. Vanessa Demas, who's also a plastic surgeon who is out in the operating room. She can't make it today. So we try to stretch out as much skin as possible. It's much like a pregnant woman after you deliver a child, you have some extra skin there. And so we again expand this as much as possible. We also had the advantage of these 3D models that helped us to kind of determine soft tissue coverage as well. And once we separated the twins and we had, this gained us at least 12 centimeters of length. We also, plastic surgeons love technology. Dr. Varun Patel alluded to that. We also used, intraoperatively, we had these studies that we can inject a dye, and you can see in one twin, you can see which side of the skin is perfused, and that helped us to determine where the incision was going to be made, and actually was a critical point to tell us exactly where the incision was going to be made as well. Can you see that? And thirdly, we had, as Dr. Emron had said, we had many vendors that were involved in this. We had a lot of tissue and biological tissue that if we needed it, we could close the exposed areas with biological tissue that wasn't available perhaps maybe even 10 years ago. And we also had some different devices if we needed them that we could close the skin with too. So all in all, we're pretty fortunate that we were over-prepared. We didn't really need as much of the tissue that we thought we were prepared for. And once the doctors, Comstock and Timberlake brought the pelvis together, it reduced the amount of space that we had there. So we usually use just really the twins' own soft tissue and a little bit of some grafting to cover the muscle. But overall, it went very, very well. Very, very well.
I just wanted to show you this because we want to show cool tools. But so Bristol is one of the first children's facilities. In fact, the only two children's facilities that we're aware of, because there's only one company that makes this, and the other one is in Dallas. But I can tell you, no one has done this on twins. Used this technology on twins, and what it is an image perfusion scanner, and we inject a dye, and then we look at the blood flow to certain organs. And it's been used in the adult world extensively. Cardiac surgeons, plastic surgeons, even the colorectal doing it. And Kevin Hopkins was nice enough to put us onto this thing, and we were able to get this perfusion scanner here. And on the top image, the top video is exactly what we're doing. They get injected, and what the plastic surgeons are doing is able to see the blood flow and a line of demarcation between the twins, because it's not exactly a nice little straight line. It sometimes follows a different pattern. They're able to mark out exactly the blood flow and mark out the line of demarcation. And from a pediatric surgeon standpoint, it's pretty cool because we're able to use the same thing on the valve. I think it's like, at this point in time, everyone goes like, whoa, that's cool. But you just look at the blood flow to the valve, we're able to look at the blood flow to the internal organs, decide exactly where we want to divide the uterus, which one belongs to which one. And these are symmetric conjoined twins. So what happens is when you inject one twin, you can actually see the blood flow to this half they inject the other one, and then blood flow to that half. I want to make it sound like it was easy, but it certainly made our life a lot easier. I'm going to just hand over, so in essence, the kids, I don't know, you've heard enough from people here that the operation went great, and from a surgical standpoint, I couldn't be happier. There were no issues, no major issues, nothing out of the ordinary. The blood loss was minimal. We thought we were going to empty the blood bank. We had notified the blood bank. We had notified reserve blood supplies. The description of blood loss with surgeries like this is pretty extensive. Fortunately, we had almost next to nothing in one of the twins and nothing too much in the other twin. So overall, everything just seemed to work out well. And we're very thankful for that. Of course, once the twins are separated after a long operation, they need to recover. We can't exactly discharge them home the same day. So Dr. Maher and his team in the pediatric intensive care unit have been, as Mr. Warner mentioned, at the bedside minute to minute, taking care of these very sick, critically ill kids. And they're not out of the woods yet, because there's a lot that still needs to be done. They will have several procedures, as we mentioned before. Jimenez already had a couple more, and I'll let Dr. Maher speak to some of their recovery in the pediatric intensive care unit.
Is this on? You hear me? Okay, thank you. Thank the team for inviting me. Actually, very rare that our unit's a little bit different. We take care of the sick. Our staff is used to dealing with usual emergencies. Anything that happens sudden, we're there. So I thank Dr. DeLeon recognizing that, he had these children and realized that we're geared up for this kind of care. All, again, contingency. Should there be something, our unit is geared for that. But normally we don't get to meet our patients before they pretty much present after the operating room. Because of this unique planning, I was brought into there about the last third of the way into this, which was very important, getting introduced with all these concepts. It wouldn't be the same thing for us, usually surprises of what happens medically. Here, we could predict it, predict the staffing we need. We had a unique chance to fuse our units between the neonatal nurses and my PICU nurses. Usually there's not a combined effort. This was necessary. These were older children, they had personalities, things we don't normally see because our children come in sick, they get a little bit better and they leave our unit. So it was quite a change from the norm, but and I've been working with the two teams since the surgery, and it's just phenomenal to have the NICU nurses knowing these children as their personalities, and my nurses working and talking. Obviously, they're quite ill to start with, and having been so involved in the surgery, the medicine here was quite different because this is very complex anatomy. Those models, believe it or not, they're a little broken because they were in my unit the whole time. Helped us actually talk to people, figure things out. When I talk to the surgeon, I'm not a surgeon, but very complicated things. But then I had the unique challenge with my team, and my partners, by the way, stepped up. The unit keeps going. We're an acute unit. We take care of every acute sick child. The sickest of the sick come to our unit, so I have to applaud them for working, keeping the rest of the unit going. Well, sometimes I had to dedicate these children because of the complexities. My partners helped me do that. I can't do it by myself, absolutely. So that was unique. I actually had the day before, I thought I'd come in for 2 hours and I stayed 11 hours, okay, to prepare even our unit, okay. They dry run the whole thing. I had maintenance, moving things the day before, realizing everything had to be spot perfect. When they came, the rooms even changed, believe it or not. We had to strategically place it, and it was just unique planning that they had done surgically, believe it or not. Just the logistics of what we did made that transition incredible, okay. And as the surgery went on, having that unique streaming to find out where we're at, preparing our nurses, was quite helpful in the preparations. And when they came, it was just amazing. The colleagues we have, the anesthesiologists, we're in the same group. They had told me a game plan the night before, those lines, every bit of it are the things we need to know that we use. So we were well informed. We were well informed of the medications, how the babies responded. And I got to say that the physiology part was just amazing. We look at how well prepared they were, how well the babies came out to us. It's just phenomenal. And they did quite well. And the unique part again would be working with the surgeons. A lot of things here seem to be medical issues, and I always had to call my colleague there, Dr. Patel, even in the middle of the night. Is this a surgical problem or a medical problem? It's such a unique case that sometimes we couldn't figure it out. We had our radiology staff coming in the middle of the night, several occasions to help us figure it out, and working together. I think the care, the children are doing quite well, okay? They're still supported on the respirators. They're not breathing for themselves yet, but this morning I think Dr. Patel got to see, and grandma and mom, both of them starting to move and waking. It's quite a sight. And our neonatal nurses, they were with these babies so long that they know these children. And now we need familiar faces as they become awakened, so they're working with us. So important, because they're part of their family. So they're there too to see these babies as they awaken, okay? Unfortunately, the mother and the family, like every normal family, they all caught a cold. And they just happened to do it right now at the time of the surgery. Was a surprise. We're geared for surprises, and sure enough, it's real. So has made issues a little bit stickier with the lungs and everything, but they're awakening, and we know how to manage lung disease. It's just, with all the rest of it, it's just one more thing we do on a daily basis. So, but again, the collaboration with the surgical teams, my staff, the fusion of these two nursing divisions has just been phenomenal. The housekeepers coming in, I mean, we're using a lot of double, like they said, and now that we're protecting from viruses and things, a lot of gowns, so this is just an amazing amount of resource, people, and I said I was so impressed that first night when, you know, late at night, I'm used to those hours, but there was so many people there helping, you know, impressed.
Thank you, Colin. Well, thank you for your patience. I know. I'm sorry, Roger. Yes, sir.
Just as I was sitting here thinking about this and what Carl just said, it reminded me of the old adage, it takes an entire village to raise a child. This reminds me it takes an entire Driscoll Children's Hospital to separate children.
It's short but concise and right on the mark, Roger. That's right. Thank you very much. As if you were expecting a short conference, remember this was a 11 months of planning and 10 to 12-hour surgery, so, you know, a 1-hour conference is not too bad. But I wanted to make sure that we covered as much as possible and give you the opportunity to ask questions to the various experts and professionals that are here. Some of them have had to leave because they have to go and work. But we'll be happy to take some questions, and I'm going to let Tammy, how are we doing?
I believe we have a.
Tammy, can we
borrow that
get Lloyd
microphone?
up, Chairman of the Board?
Absolutely.
Just say a few words.
Absolutely. There's a mic right here.
Sorry.
Mr. Lloyd Neal coming up here so we can.
On behalf of the Driscoll Children's Hospital Board and all of our trustees, I cannot tell you how really important you are to the success of this whole hospital and its effort. But I cannot tell you how proud we are of what we have accomplished here, not only all of our surgeons and specialists, but all the great support staff that we have in this hospital. Clara Driscoll would be extremely proud today of what you and this hospital have done for the children of South Texas, and particularly these Trent twins. And so on behalf of all of us, let me just say thank you very, very much. We are so fortunate to have dedicated people like you to make miracles happen every day at the Driscoll Children's Hospital. Thank you very much.
We'll allow a few minutes for questions. Yes? Okay.
Okay. I have 2 questions for you. There was a beautiful photograph going around of the prairie beds before the surgery. Whose idea was that, and how did you feel in that moment? And my second question is, how long of a recovery really are we looking at over? How long will the overall recovery take?
I'm going to let Angie answer the first question, because I know that I was in the room and I was a little late for the prayer, but Angie?
We
it was actually taken the day before the surgery. It was our last dry run, our last practice. And a chaplain had come in and came in and requested that it would be a good idea for us to do a prayer, and everybody did not hesitate. We all held hands. It was Dr. Amanu, Dr. Patel, myself, and Scarlett, a couple of the surgical techs, anesthesia techs, and OR nurses. And we sat and prayed basically for us to have the guidance and the hands for the surgery the next day. Then everybody was going to be coming in really early in the morning, and it was just a calming effect right before the big day.
I just want to know who took that picture, because I was not expecting. That was a good picture. In terms of the surgeries, the kids are going to need many, many more surgeries. In fact, Jimena's already had one extra surgery, and you might as well know because it seems like the information gets out before we release it, but she's going to have another procedure this afternoon. And so some of these are planned, and some of these are not totally planned, but certainly expected. This is complex surgery. We've mentioned before that they're going to need multiple secondary procedures. Obviously, we're trying to minimize the number we need to do, but situations arise where we might have to do something because there are, for example, a urine output may not be adequate. And a lot of this is a reflection of, as pointed out by our orthopedic and urologic colleagues, is you started off with them basically fused at the pelvis, sharing this wide, big, open pelvic brim, and now you bring things together, and you've created a much smaller space. There's the operative swelling from being in surgery for 10 to 12 hours, and so things don't exactly work perfectly. We're able to support them, but we do need to take them back periodically to, for example, change dressings. We have specific wound suction device to help with the healing. That needs to be changed. We've got some additional work to do on the ureters to make sure they're working properly and maintaining their renal function. So again, they're stable. They're, as I mentioned, not out of the woods, not ready to come off the ventilators, and they may not do it simultaneously. They may do it at different periods. Right now, Scarlett seems to be doing better in terms of a quicker recovery, but she's required less or required fewer trips back to the operating room. So I anticipate that as long as Jimena maintains where she is and we're able to maintain her in a stable fashion and sort out what I call housekeeping issues, then we'll have her back on track.
I have two questions for Dr.
Bring it on.
¿Nos puede decir en español el trabajo en equipo fue muy importante en esta cirugía? Escuché que varios hicieron énfasis que trabajar en equipo logró que fuera un éxito esta cirugía. ¿Me puede platicar sobre el trabajo en equipo que hicieron todos?
Bueno, como lo estábamos mencionando, es un equipo grande de médicos que participó en esto. La culminación fue la cirugía de la separación de semana, pero el cuidado realmente empezó desde el embarazo. Nos ayudó mucho el hecho que por medio de la cooperación y haber trabajado en grupo y coordinando el cuidado, logramos que el embarazo durara lo más que se pudo, que para 34 semanas. Facilitó mucho el cuidado al momento de nacer. Subsecuentemente nos ayudó el hecho del tamaño de las niñas, el cuidado de los anestesiólogos cuando fueron las primeras intervenciones que se hicieron durante el tiempo que estuvieron en los cuidados intensivos cuando nacieron. Como ha pasado el tiempo, ha cambiado las necesidades del cuidado de las niñas por el tamaño. También hemos tenido la participación de un gran número de personas para tratar de hacer un plan que pueda prevenir complicaciones en el momento de la operación y tratar de optimizar el cuidado durante la operación. Sabemos que la operación es bastante grande, bastante compleja Entonces, a través del trabajo de grupo, a través de, si se puede decir, prácticas de lo que fue el día de la operación, muchas de las complicaciones que pudimos haber tenido las evitamos, y las complicaciones que hemos visto estábamos preparados porque teníamos la suficiente información por la preparación y por la coordinación que hemos hecho del cuidado de los niños como parte del grupo.
Doctor, ¿cuál va a ser el siguiente paso? Escuché que Jimena va a tener otra cirugía más el día de hoy.
Básicamente,
Sí,
okay.
Aspecto quirúrgico. Jimena va a regresar de vuelta hoy al quirófano. Ella se ha mantenido estable y al parecer hay un pequeño problema en su riñón, el cual nosotros entonces necesitamos explorar para asegurarnos de que ese riñón se mantenga estable como se ha mantenido ahora, y asegurarnos de que siga recuperándose y que siga como ha estado, estable. Y básicamente, como dijo el doctor Patel, es housekeeping. Son cosas que no son planificadas, pero son entendidas y las estamos atendiendo día a día.
¿Y el estado de Scarlett? ¿Ella se encuentra bien?
Scarlett se mantiene estable, se mantiene muy bien también, y como dijo el doctor Patel, su recuperación ha sido un poco más rápida, y se debe también en parte a que no ha tenido estas intervenciones quirúrgicas adicionales que ha tenido Jimena, pero se ha respondido bien, y como dijo el doctor Maurer, están empezando a moverse, están comenzando a despertar y están respondiendo muy bien al tratamiento y al manejo.
Algo por último que usted desea agregar sobre la cirugía en general para que la gente sepa, o sea, que fue todo un éxito, algo que desea agregar sobre esto.
La intervención quirúrgica duró 12 horas, pero la planificación y la preparación fue un proyectazo de muchos meses. Y estamos en esta mesa, pero hay héroes anónimos que no están acá con nosotros, que sin ellos nada de esto hubiera sido posible, y gracias a ellos en gran medida nosotros hicimos tal vez 10 o 15% del trabajo. El restante, que es mucho más importante, y el que falta por hacer, son todo ese equipo multidisciplinario de personas que son parte de la familia de riesgo, y gracias a ellos hemos tenido un buen resultado, y vamos a estar día a día pendiente a cómo evolucionan ambas.
Gracias.
¿Tú crees que podrías hablar sobre el futuro, la recuperación de ellas que tendrán en los próximos años y meses?
Es un poco difícil predecir cómo van a hacer su recuperación a largo plazo. Ciertamente, como muy bien ha dicho el doctor Patel, y hemos hablado con la familia al respecto, ellas van a necesitar varias intervenciones en el futuro, eso es de seguro. El tiempo, todo depende de cómo respondan ellas. De necesitar terapia física, de necesitar algún otro tipo de acondicionamiento físico, es posible que eso también se tenga que adentrar a la estrategia, pero en este momento estamos viendo su recuperación a corto plazo. Yo creo que ellas van a seguir viéndose con múltiples especialistas en el futuro para seguir lidiando con las diferentes situaciones que cada cual individualmente puede presentar. Y eso, entonces, las estrategias se van a establecer con el tiempo.
Yo sé que hace unos momentos estaba hablando sobre su papel en esta cirugía. ¿Nos podría explicar eso en español nuevamente?
Sí, claro. El aspecto de la reconstrucción urológica, del sistema urológico, lo que hicimos fue asegurarnos de que cada cual de las niñas pudiese tener un aparato urinario funcional. Al nacer, ellas compartían vejigas, y lo que hicimos fue entonces, para poder dividirlas exitosamente, teníamos que dividir esa comunicación y restablecer entonces la funcionalidad del sistema urinario. Y en parte ese fue el enfoque urológico de la cirugía, que obviamente no pudo ser posible sin la asistencia de los cirujanos, de los ortopedas y por supuesto de los cirujanos reconstructivos.
¿Cuáles fueron algunos de los retos que usted enfrentó durante?
I'm sorry. It's great. I agree with everything they said. So we're going to take a question from each of the media people if you want, and then I'm going to allow people to just do individual interviews afterwards. Is that fair enough? So we're not here all the time. So if we can take this, give you an opportunity to ask one question that we can answer here, and then everyone here will be available to do an interview with you right after so that we can cut this news conference off at a reasonable hour. Is that fair enough, Tammy?
Yes, perfect.
Great. Okay, so who hasn't had a chance to ask a question? Yes, ma'am.
Okay, Dr. Patel, this is probably for you. We know Jimena had a couple procedures the day after the initial surgery, and you said she has another one today. Family had said she had some kidney complications. Is there a reason why Scarlett is doing a little better than Jimena, and what were those complications?
So we call complications when we have to, and we don't like calling complications as a term, but so I wouldn't exactly call it complications. It's let's say an expected, it's not unusual for patients who have had complicated urologic reconstructions to require subsequent procedures. Having said that, they're identical, but not totally identical. As Dr. Cruzias pointed out there, kidneys were not exactly the same. So for example, Scarlett has two kidneys. They're not exactly in the normal location, but Scarlett required required some reconstruction, but less than Jimena did. Jimena had one functioning kidney, and not to get too technical in detail, but essentially they both at risk for infections because they have what we call vesicoureteric reflux. Try to say that fast. But essentially what happens is they're at risk for infections, and if you've got one kidney, you can imagine that those infections likely cause damage to that solitary kidney. And I think the thought process of my partners, Dr. Cruzias and Smith Harrison, was to try to protect that kidney as best they could. And so in doing that, they did what is called reimplantation and put the ureter into the bladder to prevent reflux. 99% of the time that goes great, but occasionally when you're dealing with conjoined twins, once a week I guess, no, when you're dealing with conjoined twins, you have to bring everything together. There's so many moving parts, and there's a lot of swelling, and you've had a long surgery. There's bound to be some pressure, compression of structures, and just not the ideal working of that kidney. She has one kidney, but it's not normal either. And so what we're trying to do is optimize that for her. And so I don't think this is a complication as much as we did what we anticipated was necessary, but you know, one twin was able to do better than the other because her makeup after reconstruction is not exactly identical. Plus, you know, the way we respond to surgery may be different. Some of us swell more, there's more compression of structures. So I'm not too worried about I'm not too worried about Jimena having a few extra surgeries. It's not ideal, but it's necessary. And yes, if we don't do these surgeries, there will be complications. So it's almost a preemptive strike if you want to think of it that way.
Anyone else have a question for the group? You're ready to do individual interviews. Everybody ready? Thank you all for coming, and we'll start in a minute.